Hello, dear viewers. My name is Susanna Zsoter. I am a patient expert in oncology for gastrointestinal tumors. And today I have the opportunity as a patient representative to discuss the latest exciting study results from the ESMO Congress together with Professor Lordick. Hello, Professor Lordick.
Hello, Ms. Zsoter. I am very pleased that we can once again discuss and review these results together today. In fact, the ESMO Congress took place just a few days ago. And I have three very interesting and also groundbreaking studies here in this session. For the treatment of patients with gastric carcinoma, I am usually working at the University Cancer Center in Leipzig, leading the oncology and gastrointestinal. Tumors have been a focus of mine for many years. Here I will show you potential conflicts of interest arising from research support, as well as consulting and lecturing activities. And I will now move on to this main topic of stomach and esophageal cancer. But it is more about patients with stomach cancer. Here we presented a very important study within an international consortium on which we have collectively worked for almost 20 years. This is about patients who have a type of stomach cancer that is operable but already locally advanced, as we call it. Most patients with stomach cancer are not diagnosed in very early stages because stomach cancer in these very early stages simply is not detectable. These are small changes in the gastric mucosa that patients do not feel. They usually only feel it when it is more advanced. Then the question has always been what should be done. Is it surgery alone or chemotherapy around it, or does radiotherapy also play a role? So for whom is the study relevant? For those patients who have stomach cancer at exactly this stage or located at the junction of the esophagus and the stomach and whose cancer is still operable, meaning it can be treated surgically. The study included approximately 600 patients. These patients lived in Europe, in Australia or in Canada. This has been a large international consortium. It really took a long time for the study to get underway and for these patients to be found who were willing to participate, and now we are finally able to present it and have even published it. These nearly 600 patients were randomly assigned either to chemotherapy treatment or chemotherapy and radiotherapy, then underwent surgery, and after the surgery, all patients received the same chemotherapy again. So the difference in the approach lies in the phase prior to the surgery. The study was designed with the question of whether adding radiotherapy would improve the survival of the patients, and there are also secondary endpoints that were considered. Here the whole thing is presented in a different way. So it examined whether a radiochemotherapy, radiation, and chemotherapy before surgery, in addition to chemotherapy, improves treatment outcomes. Chemotherapy is now the standard. We administer it both before and after the surgery in this situation. That is, the so-called standard arm and the investigational or experimental arm include radiotherapy. This is a very relevant question that we have been discussing extensively over the past 2 decades. Is the survival of the patients better? And does the disease progresses less when radiotherapy is added? But also, of course, what are the side effects? How is something like this tolerated when 3 types of treatments, radiation, chemotherapy, and surgery are used together? Here is one of the secondary endpoints, namely how the tumors have responded. This can then be observed when the stomach is operated on. It can be closely examined under the microscope to determine how many patients' tumors have completely disappeared. And there, the additional radiotherapy has already had an effect. In more patients, the tumor had gone into complete remission, so it was no longer detectable when radiotherapy was added. One knows something like this relatively early in the course of the study because the stomach is operated on and then one immediately has this result. But the crucial point is, how is it in the long term? Do patients really benefit from it? And here I show the survival curves over a long duration spanning 5 years and even up to 6 years with 72 months. And here you can see that the addition of radiotherapy did not further improve the overall survival chances of the patients. Gastric carcinoma is, as can be seen from these declining survival curves, still a difficult tumor. Nevertheless, much progress has already been made. This would have been much more aggressive 20-25 years ago. We have already achieved quite a bit through good surgical methods, through perioperative chemotherapy, but adding radiotherapy has not proven beneficial here. One can also look at the side effects. You can see from this table, and I won't go into the details here, that of course the additional radiotherapy also caused more or stronger side effects in certain cases. But I am not going into the details here because now the radiochemotherapy will not become a standard anyway. So it would have been tolerable, and it also led to a better response from the tumor, but in the long term, it did not prove beneficial for the patients. So, one can already come to the conclusion here that the addition of radiation to chemotherapy before the surgery of a gastric carcinoma does not improve survival chances. What does that mean? The patients do not need radiotherapy. This makes the approach somewhat more streamlined and simpler in terms of feasibility, which is already an important message in itself. And perhaps in individual cases, when an immediate response is urgently needed, then one might consider whether to include radiotherapy, as it has shown that it actually works in the stomach, but it is likely that this will be only considered for a very small number of patients in the future. And maybe we will discuss this later, because the other two studies could perhaps even be discussed together, as they report on a different tumor stage and also a different patient group.
Yes, with much pleasure, and thank you very much. This is really a very fascinating study. I actually expected that you would say when you initially presented the first numbers, where you mentioned that in some cases the tumor was no longer detectable, that this might mean that we have a potential new standard therapy here. But I find it truly astonishing and interesting to see that in the long term it actually doesn't provide any benefit for a patient.
That is actually really interesting, and indeed we are also discussing, among others, these matters extensively within professional circles. I believe, however, that with gastric carcinoma we already have a good explanation for this. Because what makes gastric carcinoma dangerous in the long term is that by the time of the surgery there may already be so-called micrometastases. So, metastases in distant parts of the body, wherever they may be, which we cannot find. Although the patients are thoroughly examined with computed tomography and laparoscopy, and all the other methods we can use, and a radiotherapy which can only be directed locally at the stomach, cannot be spread throughout the entire body, that would not be tolerated. It cannot have any effect on these micrometastases, because they are already present and outside the radiation field. And we now know from this TOPGEAR study that I just showed, as well as from other studies, that the prognosis is then determined by what happens with these micrometastases, whether they eventually become active again after 2, 3, or 5 years, or whether they remain inactive, and here the best possible chemotherapy, or, as we are now also exploring approaches with immunotherapies and with other biological treatment measures. At this point, it is simply more important to optimize them, rather than optimizing the local effects on the stomach, for example.
Yes, that's true. One has often, when such a diagnosis is made, the urge to get rid of this cancer as quickly as possible. One considers the short-term goal, but often as a patient one doesn't fully understand what the long-term effects will be. And there, I find it really important that there are studies showing that a particularly aggressive treatment at the beginning does not necessarily provide the benefit one might wish for when going through it. However, I also believe that this requires quite a lot of explanation from the healthcare providers to the patients in order to really make it clear to them. But I think it's great that there are now actually data that can prove this with numbers.
Although I must actually say, it is always very important that the treatment team is in agreement, that there are guidelines in place, and this chemotherapy around the surgery is now recommended in the guidelines in Germany and also worldwide. And we actually no longer have so many difficulties explaining this standard approach here to our patients. And above all, we speak with one voice. We don't have any disagreement between surgeons who say it must be removed immediately. Instead, we now know from the study data that it is the best approach, and then patients also understand this and are happy to accept it. Such a contentious point could indeed be that one might now say that in the radiation and chemotherapy arm, 16% of the patients had a complete response. Couldn't the stomach have been left in place? And this consideration is indeed very valid. We will see more data on rectal cancer in another presentation, where we are actually now offering such procedures, where surgery is not performed at all, but instead only chemo and radiotherapy are used. With the stomach, we are still uncertain whether that is possible because we cannot detect as reliably whether there is truly no tumor left in the stomach. The stomach is a complicated organ, therefore we still recommend to all patients with operable gastric carcinoma that the surgery is carried out, and very rarely make exceptions to this recommendation that we discussed.
I'm curious what we'll discuss in the years ahead. Perhaps there'll be data on this by then.
It continues to develop, yes indeed, and since it continues to develop, I could show you in the next two studies which were conducted in a different stage, namely in the stage when patients already have distant metastases, meaning there is no longer any prospect of achieving a cure through surgery. This is also a reality in our everyday life that we are treating patients with metastases. And we have had chemotherapies here for many years, which I think are generally well-tolerated chemotherapies, mostly well-tolerated chemotherapies as the standard, but there is, of course, a constant effort to improve these therapies. And now I will show you two improvements from the very recent past, just presented at the ESMO, which are now also available to patients. Here I present you Spotlight and Glow. These are the studies that we also presented at the ESMO Congress, in fact, in conjunction. Both the Spotlight study as well as the Glow study were already published in full publications last year. But now we have summarized the data from two studies, and this makes sense because it has resulted in very robust evidence. These data are specifically relevant for patients with stomach cancer or an adenocarcinoma of the esophagus who are locally advanced and inoperable, or where most have distant metastases, who were included in this study, who were not treatable by surgery. HER2, that is a marker we have known for a long time, negative, and Claudin 18.2 positive. Claudin 18.2 is likely a new term for many people, and for many patients. It is actually a more recent discovery. It was discovered in the late 2000s, around 2007 to 2008, when it was recognized that many gastric carcinomas carry a protein on the surface called Claudin 18.2, and that is very characteristic for the stomach and does not occur in other healthy organs. And that is a target structure for a medication called zolbetuximab. This medication is new, and this medication was studied in this patient group that I just described, in combination with chemotherapy, as you can see here, or compared with placebo and chemotherapy. So all patients received chemotherapy as the standard, but only half of the patients were randomly assigned to receive zolbetuximab, while the other half received a placebo, because we need to find out, what does zolbetuximab really add in terms of progression-free survival time? That is, the survival time without the tumor growing, ideally responding. And what does it do to the overall survival chances of the patients? There you can see again what exactly was investigated. The addition of zolbetuximab to chemotherapy. Zolbetuximab then binds to Claudin 18.2. It is a biological agent and thus marks these cancer cells, activates the immune system against the cancer cells, and leads to improved and more prolonged elimination of the cancer cells. These are all things that we already knew from the studies we have conducted over the last 10 years, but now a direct comparison between option 1, chemo with zolbetuximab, versus chemotherapy alone, or with the placebo treatment added. And here you can see the summarized results regarding progression-free survival. There are now over 1,000 patients in total who were included in this study, where Glow and Spotlight were illuminated together. And you can see here, the red curve represents the group that received the additional zolbetuximab, and the gray curve, the mortality curves, as we call them, show chemotherapy alone. And there you can already see a significant difference. Of course, we would always wish that the difference was much greater. However, this is very, very difficult to achieve with gastric carcinoma. With such a challenging disease to treat, we are indeed very pleased to have achieved this next step forward. And you can actually see that some patients have remained stable, even at 2 years, at 3 years, so over a reasonable period, as we must say, for this aggressive disease truly under control. So the curves do not converge. This is not a temporary short-term effect, but a long-term effect that can be observed. And the same applies to the combined overall survival from these two studies. This really shows a sustained effect of zolbetuximab throughout the entire observation period, which is now quite long, when this protein Claudin 18.2 is sufficiently expressed on the tumor cells. And that can be examined under the microscope, and there are defined values, namely 75% of tumors must be positive for Claudin 18.2 for zolbetuximab to demonstrate the effectiveness shown here. And unfortunately, as always in cancer therapy, there is always a certain price to pay in terms of side effects. Not even mentioning the medication price, as we don't know it yet. It is just now being introduced to the market. A few days ago, the European approval was granted. But I mean here the price you pay in terms of side effects. The zolbetuximab, because it causes irritation in the stomach, unfortunately leads to nausea and vomiting more frequently. This is of course uncomfortable for patients, and has also led to an increased number of patients in the studies after the first or second treatment saying, I don't want to continue anymore. This is too much for me, having such severe nausea and vomiting for several days. There is, nevertheless, also a good message. As soon as this second dose is overcome, then this side effect significantly decreases or even disappears. Then you no longer see that it is more compared to chemotherapy alone. And as always, when we have new medications, we learn to manage it better. And by now we know what kind of protection against nausea and vomiting we should definitely provide. We can also introduce modifications regarding the infusion speed to make it somewhat more tolerable, allowing me to not discourage anyone. It is indeed an important medication. We as healthcare providers must know how to deal with it, and still need to learn that, quite certainly even. And we just need to guide patients well, inform them properly, and encourage them to try the first 2 or 3 doses to see if the whole thing becomes more tolerable. Because no one would want to miss out on the long-term effect I showed you earlier, the positive long-term effect. That would be the important message. So summarizing the data has confirmed once again that zolbetuximab is an effective new treatment option added to chemotherapy when metastases are present or in the case of a locally advanced disease. The nausea and vomiting must be really taken care of. We take this very, very seriously and are committed to optimizing it to make it as tolerable as possible. We have already included the recommendation for zolbetuximab in the guideline. I just have revised the European guidelines. It's included there. We are currently revising the German ones. It will also be included there. And I have already said this is now available. That is, what does this mean for everyday life? This can be offered to patients in the near future. All that's left is for it to be brought to market by the company that manufactures it. However, this will not take much longer. I can't say exactly how long, but I think it is only a matter of a few weeks before this drug will be available from the pharmacies. And what is crucial is the identification of patients who can benefit from it. They need to be positive for the marker Claudin 18.2 in the tumor. So it must be determined by our pathology colleagues. But they have already learned how to do this, and the implementation of these tests and corresponding control mechanisms is now in progress. And now I might briefly move on to the second study and second innovation for nearly the same patient group, because we can then discuss it together, Ms. Zsoter. This is now a study called KEYNOTE 8111, which does not refer to the HER2 negative patients, but to the HER2 positive patients. For a long time we have had a standard treatment consisting of chemotherapy and trastuzumab, which are antibodies against HER2. And now it has been tested to see what the addition of pembrolizumab, another antibody that stimulates the immune system, adds to the treatment. So patients with advanced stomach or esophageal cancer, mostly metastasized, not treatable by surgery, HER2 positive. New treatment forms have not yet been previously used on the metastases. Again, a study that makes an exact one-to-one comparison between the standard therapy, which you can see here on the right, with either a placebo or the standard therapy, with pembrolizumab. We already observed progression-free survival last year, and overall survival has now been newly presented at the ESMO Congress. Here the options are presented once again. I believe I have explained them enough. One can take another look at it. And this is the overall survival that was shown. So here too, for the group of HER2-positive tested patients, a new standard because the patient survival has improved. The substance is already available. Already last year, when we saw the progression-free survival data, the European Commission decided to approve it. And now there is the confirmation that overall survival has also improved. There are also subgroup analyses. You can see, for example, and I always find this very important, that women benefit at least as much as men. We are now often very gender sensitive in our assessments, because we know that is not always the case. Here, women might even experience a particularly strong effect. It could also be coincidence, but it is somewhat reassuring. The non-Asians have a strong effect. Even there, we sometimes see differences in effects among Asians, non-Asians, or specific population groups, for instance. So, this is all, let's say, quite reassuring for us. And we see that another biomarker still needs to be determined, namely PD-L1. Because if PD-L1, an important immune marker, is not present on the tumor cells, pembrolizumab cannot be effective here. So this must also be determined. But in most patients, HER2 and PD-L1 are positive. So these are the good news. If HER2 is positive, PD-L1 also must be considered, but in most cases it is positive as well. Side effects are not as severe anymore, although when looking at a table like this, there are still some numbers that are a bit higher. What we know is that when we administer immunotherapies, they can always also trigger immune reactions. After a few weeks, also after a few months, and very rarely even after a few years, an immune reaction can suddenly be triggered in the body against the skin, joints, intestines, or liver, which can be significant. So a so-called autoimmune reaction, this can then manifest as the affected organ is causing problems. Joint pain, skin rashes, liver inflammation, diarrhea. I would say we have also learned to handle this very well, but we need to be highly attentive and also educate patients to report anything unusual and always keep this in mind. In some patients, the function of hormone glands may also be impaired, so that, for example, the thyroid gland no longer works as it should. These patients then need long-term thyroid medication, so there are quite a few things to consider, but I would say I want to emphasize the good news here. Pembrolizumab helps patients to live longer and better, and we can usually manage the side effects well together with the patients. So in conclusion, this is a new standard therapy, adding pembrolizumab to HER2-positive tumors. Then if PD-L1 is also positive in addition to HER2, the combination is feasible, pembrolizumab and trastuzumab and chemo, and for the everyday clinical practice, it is very important not to forget to determine HER2 and PD-L1 in advanced stomach and esophageal cancer. And then reflexively, if both are positive, to discuss this new option with the patient, and I believe there will be only a few patients to whom it cannot be offered. This can be the case for patients who have previously had organ transplants or patients with a history of severe autoimmune diseases where one might say this is not possible. But for the majority of patients, it would be possible to administer this. That's it from me, Ms. Zsoter.
Yes, thank you very, very much. That was really exciting and also very interesting. I find it quite impressive to see how our growing understanding of the molecular genetic causes of a tumor strongly influences treatments and also offers so many more and new possibilities. That is just absolutely and totally impressive. So we already know the checkpoint inhibitors from different indications. They were right at the beginning with the skin. And I find it great to see how the growing knowledge, along with existing drugs, is making other types of cancer treatable effectively and for a long time.
For me, there is actually also a question for you. This has all become quite complicated for us by now. And with the markers and these large control panels and so on, is this something that is also being discussed among patient circles? That nowadays you almost have to study textbooks to even understand what is being done to you, what is being offered? Or is it rather seen positively with the notion that science is progressing? They can look at many characteristics of my disease, and from that they can derive the best possible treatments? How is this perceived from the patient's perspective, Ms. Zsoter?
I believe there are two groups of patients that we need to distinguish a little. There are people who simply do not want to engage with it or are unable to do so and trust what is being offered to them. And for them, of course, it is incredibly complicated because then suddenly a stomach cancer is no longer just stomach cancer. The stomach cancer is not the same as stomach cancer, and they are treated completely differently. And then it can sometimes happen that there is a lack of understanding. Why is my cancer now being treated so differently from the cancer of person B who is sitting next to me in the treatment chair? That is, of course, very complicated for patients. But I also noticed that it's not necessarily always the patients themselves, but often also their family members who are very engaged in understanding what options are available, and they are also highly motivated and eager to ensure that such testing is done. And then they also ask if there might be any markers or if this could work. And I actually welcome that very much because it strongly moves in the direction of the informed patient. Good decisions can be made, and it can also be explained easier and more quickly what it means to be treated with such a therapy. Especially with checkpoint inhibitors, a patient needs to pay attention and recognize side effects earlier because they are completely different from those typically seen with chemotherapy.
Yes, you're right. And besides, sometimes it is also possible that the patients also come motivated from such conversations and ask about options. Sometimes you really come up with new ideas together and say, you are right, we can double-check that point. Sometimes that is certainly very interesting to see which important thoughts are articulated again. We also have patients who come specifically due to the activities of patient groups and ask if there are studies available in this area. So a lot of positive things can result from that, even leading to more routine side effect management. When you are in contact with other patients who say, you should also pay attention to this and don't keep that to yourself, better call them again. This could be a dangerous side effect. So I can only agree with you. Informed patients indeed can, sometimes indeed also contribute a great deal to their treatment success and management.
That is very important, and I believe we must not get tired of saying again and again that we must always stay up to date in a clear, understandable way. This is a complex topic, and it's very important to give information in a way that's understandable for patients, just like we are discussing it now, and explain very simply, okay, the reason that this indeed works so well is due to this or that. And as soon as a person understands how the whole thing works on a very, very basic level, that's often enough already, then a lot is already gained. But I believe that there will also be a change in the information behavior in the future with the increasing knowledge in oncology, even among the patients, even significantly.
I hope I explained myself clearly. As I previously said, it truly brings me joy to have the opportunity to share and discuss these information and results with you, Ms. Zsoter.
Likewise, it's so much fun every time, and I learn so many new things each time, and I am thrilled how our research in medicine keeps progressing and progressing.
That's it for now on stomach cancer. Soon more updates on new congresses and opportunities to discuss further developments. Thank you, Ms. Zsoter.
Thank you. Have a good day. See you next time.